Registered Dietitian at the New York University Langone Medical Center's Comprehensive Epilepsy Center in New York, New York, with 13 years of extensive pediatric clinical nutrition experience. She works with patients of all ages, but specializes in pediatrics at the inpatient and outpatient clinical levels. She completed her bachelor's degree at Syracuse University and her master's in clinical nutrition at New York University, and is also a certified specialist in pediatric nutrition and a certified lactation consultant. She currently helps individuals navigate the ketogenic diet therapies for epilepsy at the Comprehensive Epilepsy Center, as well as managing her private practice, Courtney Glick Nutrition, where she sees pediatric patients for a range of nutritional concerns. What is a registered dietitian, and what is the difference between a registered dietitian and a nutritionist? Because they're very different.
Yes. So a registered dietitian is somebody who's been through a rigorous amount of coursework in order to gain that credential. So RD is a national credential, just like RN, just like, DO, DM. There's an actual board certification behind the RD. In order to sit for your RD certification, you have to pass through what we call a didactic program. So you have to sit for a certain amount of hours in your field. You have to do coursework, and you have to do an academic program. So you have to do either an undergraduate program, a master's program, and then you're eligible to participate in the internship. So the internship is basically like any other internship that a clinician would go through. You're in the hospital and outpatient in all the different kind of sectors of nutrition for a year. And you go through all of these stages to see where you might be interested in working. It gives you exposure to adults, long-term care, pediatrics, diabetes, everything. And then once you've completed your internship hours, you're then eligible to sit for your registered dietitian exam. A nutritionist, unfortunately, there aren't a whole lot of parameters defining who a nutritionist is. So you can go out tomorrow, take a few nutrition courses and say, I'm a nutritionist. And there are even states that don't mandate that you have your RD in order to practice. So this is a bit confusing, but there are two separate credentials. So there's the RD, which is a national, board certification. Right. And then every state has what we call licensure laws. To practice, states are, as we've seen during the pandemic, states are really left up to their own devices with certain things. And this is one of them. So to practice nutrition in most states, you must have an RD, but there are a few states, they're moving towards having RD as a credential. There might be only one or two states left now. New Jersey was one of them a few years ago, but I believe that they've switched over, that you don't need to have your RD to practice nutrition. Now, New York does. You must also, in addition to having your RD, have a state license. And that state license is about the same type of qualifications that your RD. So this prevents anybody from going out there and calling themselves a nutritionist. So an RD has really been through a lot of rigorous coursework, and that's really sets them apart from just anybody who's focusing on nutrition. They're specialized to deal with chronic disease and illness instead of just telling you what you should eat for breakfast tomorrow.
So yeah, if you have a health problem like epilepsy, you should go to a registered dietitian, then a nutritionist. I do think that there's a lot of, you can call it, fraud is just the word that comes up. That's not the right in terms of this context. We'll have people who want to claim themselves as a nutritionist.
Of course.
And have no experience, not to the extent that clearly you guys do. It's like taking a few courses. Oh yeah, this is what I think you should do.
Exactly. So it's totally fine also to take diet advice, and that's kind of what we would call it, from your personal trainer or your dentist. But if you have diabetes or epilepsy or celiac disease or chronic illness, those people are just not qualified to give you what we call medical nutrition therapy. So that's really the kind of cornerstone of what registered dietitians provide. They don't just provide diet counseling. We're really trained to provide medical nutrition therapy, which is precisely what the diets for epilepsy are. They're medicine, they're nutrition instead of medicine. And you really should only be going to a registered dietitian for those types of things.
Right. No, of course. So what are the most common nutrition problems? And you can expand, I guess, with, broadly also in addition to epilepsy. I know we're going to talk mainly about epilepsy, which is your specialty, but just, common, what are the most common?
So with adults, our most common, people are coming to us for, weight loss or weight gain, depending on the person. They're also dealing with, metabolic disorders, which are things like, type 2 diabetes, heart disease, those types of things. And for children, it can really span the gamut. There can be anybody coming to a dietitian for, help with their infants transitioning from formula or breast milk to solids. What do you feed your kid for the first time? And then also any of the child, they tend to be associated with adolescent nutrition issues, which are like celiac, inflammatory bowel disease like Crohn's and colitis, and type 1 diabetes. Those are things that we see patients a lot for. In the epilepsy world, we're really only seeing patients for diet as a way to treat epileptic seizures. So we're using the diet, as an adjunct in some situations to the medicine and to other therapies. And in some places, we're actually using it as the main source of therapy to treat their seizures.
Yeah, no, absolutely. I look forward to talking about the keto diet, which is used widely among not even just epilepsy.
Very popular now.
Yeah, very popular. Well, I take medication. I don't need the keto for seizures, but I know friends who take it that just because they like it, for weight loss, whatever the case.
Right.
Like, okay, you guys. All right. So, and we'll talk about specifically the keto diet and epilepsy. But so when you see a patient who's been referred by Orrin or Dr. Devinsky or, anyone in the Epilepsy Comprehensive Center at NYU, how do you assess the patient and then develop a ketogenic diet plan, quote unquote, to treat their epilepsy?
So this, is probably the most extensive step of what we do, other than the support that we provide for the families. But when we meet with a patient initially, we spend anywhere from 90 minutes to 2 hours with them, kind of going over all of the history. Do they have allergies? Do they have food preferences? Is the diet going to work for this person lifestyle wise, as well as based on the types of seizures they're having and the medications that they're on. So a lot goes into it. We sort of put our heads together with the team and see, do we think this patient is a good fit for the diet? The diet has very few clinical side effects compared to medication, but it has a lot of psychological and lifestyle side effects. So we have to address that as well. So we really sit down, we assess the patient's height, the patient's weight, how many calories we might think they need, what are their food preferences, and we develop a really extensive plan on how to start the diet and then how to remain on the diet. And this involves calculating almost every single meal that they're going to consume when we're talking about the classic ketogenic diet. And then when we're talking about the slightly less rigorous diets, like the modified ketogenic diet, this involves really teaching parents how to implement the diet at home. So, most of that initial session is assessment and deciding, what diet, how many calories, what's the meal plan going to look like, what's their day going to look like. And then the other half is done really teaching the parents and the caregivers how they're going to implement the diet. How is this diet going to look like? What is it going to look like at home? What are their 3 meals going to look like and their snacks going to look like? How's it going to fit into their lifestyle? I'm going to spend a lot of time doing that.
It's starting to work. But I don't know what's going on. It's just okay, continue.
So a lot of it is education. There's a huge education piece. There are a few different versions of the diet, which would take me, probably the whole interview to explain the differences between them and what they are. But when we do the more intensive ketogenic diet, it involves a lot of weighing and measuring of food. So a lot of time is spent teaching families how they're going to weigh, how they're going to measure, how they're going to put together. And then on the back end, we're doing a lot of recipe development, a lot of meal plan development. That's kind of, 90% of what we do.
Right.
And the other is just supporting the family. So they have a lot of questions as they go on, but we do a full, health assessment when we see them, and that's basically how we determine what the next steps are going to be.
Right. Well, yeah, and full assessment is how you determine a patient's quote unquote plan. So actually going back, I should have started this. What is, for those that don't know, the ketogenic diet, but primarily for those that have epilepsy, not just, what you read in the media and, the fasting and everything else that goes with just, the mainstream ketogenic diet that people know of.
Right. So the ketogenic diet, when we talk about ketosis or, getting into ketosis, we're really referring to a metabolic shift in our body's metabolism. So we primarily use sugar as an energy source, which is carbohydrates. They break down into sugar in the body. We also use fat and protein, which break down into amino acids, and fat break down into lipids, which then are converted to ketones. So the end product of fat digestion are ketones.
Right.
The body will always use sugar as its primary energy source. And unless we force the body to use a different energy source, such as fat or protein, it will just keep on using sugar. So the ketogenic diet restricts sugar in the diet in order to force the body to use fat. That creates a state of ketosis. So it's kind of this broad name for a ton of different metabolic pathways that change when we change our metabolism. So different hormones are increasing, other hormones are decreasing, but mainly the main, to simplify it as much as I can, because it's a very complex process, ketosis is the body changing from using sugar as its primary energy source to using fat as its primary energy source. That shift in metabolism, we don't know exactly why it helps people with their seizures. There are a few theories out there, but the shift in that chemical shift somehow decreases neurotransmitter activity and improves seizures in some people.
Yeah, that's amazing. And so the ketogenic diet can be substituted with medication for treatment, correct?
So a lot of our patients that are coming to us to start the ketogenic diet are already on a lot of medications. So they're either coming to us because their seizures are not fully controlled, and the diet can give them what we call like an edge, just to kind of take that edge off of what the medications are largely doing. And other people come to us because they're having side effects from their medicine. So, maybe their medicines are making them tired or they can't focus, and we're trying a different pathway. So most people are on medicine when they come to us. We do have the occasional infant, which is the parent does not want to try medication first. They'd like to try diet first. The diet is usually not indicated until you've tried and failed 2 or 3 medications, but there are certain situations like with infants and infantile spasms where the diet can be used as a first line of defense in treating epilepsy. So most of our patients are on both medicine and the diet, but a lot of our patients have come off medication successfully and remained on the diet as their main treatment. So the diet definitely can do the heavy lifting. It doesn't generally, because practitioners are more comfortable with medicine. It's just the way we've been practicing medicine for a long time. So the diet is relatively new in the sense of the medical world. So, the first epilepsy drugs came out in the 20s, and now, they were really popular in the 50s, like phenobarbital was really popular in the 50s. And then the diet came onto the scene in the late 90s. And, it was around earlier than that, but it wasn't widely used. And now it's just being used so often. But people are still kind of in that comfort zone of using medicine. So it depends on where you go and how comfortable they are with the diet. But generally, people are on medicine plus the diet.
Yeah, that would make sense, especially those that have more severe epilepsy.
Yeah.
So, okay, so there's tons of recipes and great food that somebody on the diet can have. Can you just give a few examples? I know there's tons of examples, but just I don't know, give like a few, I guess 3 different types of meals that somebody who is on this diet can have?
So, first and foremost, when it comes to the diet, I know the diet is used a lot for a lot of different
Right.
things now. The keto diet can be pretty intense, and it's really not suggested for people who don't have epilepsy or a neurological condition where the diet has shown promise. There's a lot of studies happening right now with different neurological issues, Parkinson's, Alzheimer's, dementia, autism. There's all different focuses with the diet. So, anybody who's starting the diet for a non-medical reason, we don't suggest it. It's not something a lot of people are using it for weight loss. It's like a bodybuilder type thing. But anybody starting it for a medical condition should always do it under the supervision of a registered dietitian. So I just always say that before I'm going to give examples of meals. So, a typical day for our children on the modified ketogenic diet would be something like eggs with bacon and avocado for breakfast. Maybe they'll be able to have something like a slice of a low carb bread. So there are flax breads out there. There are almond flour breads out there that they could definitely have. So it really will depend on their preferences. We can make, ketogenic pancakes using macadamia nuts and eggs. The food has come a long way in people's creativity. Lunch may look like probably a protein source like a chicken or a salmon or beef or shrimp or whatever the person might want, with a heaping portion of like a non-starchy vegetable such as cauliflower, zucchini, broccoli. It might include dairy also. So if somebody is a cheese lover, they can add cheese. And then generally we're not adding additional starches there. So really the thing that we're missing from a traditional diet is your starch portion. So while somebody may have bread or grains or pasta, they're not going to be having that item on the ketogenic diet. And dinner looks fairly similar to lunch. You're looking for a protein source, vegetable source, and then sprinkled in there are lots of nut products, dairy products like cheese sticks for lunch, and a handful of walnuts for a snack, and also some of our low carb items, like I mentioned, the ones that we use, like almond flour, coconut flour. There's all different options out there nowadays in terms of what you can create on the ketogenic diet. People have become really, really creative. Our kids on the keto diet the classic ketogenic diet will have just kind of a smaller version of what I just mentioned. So their meals are much more controlled portion wise. That's what gives that diet a slight edge in terms of efficacy, because it's much more controlled. It's really highly calculated, and we reserve that diet for our youngest patients who are already consuming really small portions. They don't necessarily have very strong preferences for food yet. And so that will look pretty much the same as what I just mentioned, just slightly more fat. So I mentioned the proteins and the vegetables, but each meal is going to have a fat source as well. So breakfast, I mentioned the avocado. Lunch, you may have to be putting, a few tablespoons of oil, few tablespoons of mayonnaise. Some people prefer heavy cream. So it really just depends on what your fat preference is, but there will be a source of fat at each meal. And that's really what makes it so different than a traditional diet. You're generally not adding globs of butter to your dinner, but our patients on the ketogenic diet most certainly are. They're adding fat sources at every single meal. And I think people automatically think of butter and not necessarily something like macadamia nuts or an avocado or, a few tablespoons of olive oil.
Right. Or carbs.
Right.
Yeah, no, I wouldn't. Well, it'd be a huge change for me if I had
it's a big change for it.
I mean, I'm a string bean in the sense that I weigh 110 pounds and I'm 5'2", but yeah, I have to have pasta or
right.
Or rice like every single night with dinner. And obviously somebody's just serving vegetables. Of course, I can just eat all that, but I need my carbs. They're very, very filling. But anyways,
and so we wouldn't suggest the diet for somebody, who's generally, even anybody who, wants to try it for weight loss. It's really not something that we suggest. The ketogenic diet it's a medical diet. It really is. And it can be dangerous when you kind of approach it on your own. So it's important to know, like, this is not it's not a balanced way of eating. But it serves its purpose for people who have epilepsy. It works very, very well.
Yeah, no. And that's what we're talking about. We're not talking about, oh, I need to lose 5 pounds.
Right.
No. So what are some of the unique challenges that you face as a dietitian?
So the
A
most
lot. Just give me two. I know I'm asking a lot of broad
yeah.
questions.
Well, the most unique thing a problem I face as a dietitian at the Epilepsy Center is trying to manage food preferences, allergies, with the diet's restrictions in themselves. So, our society is really, really focused heavily on food. We use food for celebration. We use food for commiseration. We use food when we're happy, when we're sad. Really, food is at the root of everything that we do. People have very complicated relationships with food and their bodies. And I think that's really the most challenging part of being a dietitian, especially in today's culture. We know that not everyone is going to fit into this standard of health that has kind of been put out there. Everybody's genetic blueprint is different when they're born. So not everybody is going to weigh 110 pounds and be 5'4", even though the BMI calculator says that's what you should be. And I think that's really the most difficult part about being a dietitian is that you're really trying to help people improve their health. And I think we have such a hyper-focused diet culture on weight, and that's definitely the hardest part. I think it's walking a really fine line between, we've been fed this kind of narrative that obesity is a huge problem in the United States. And I believe there's a new statistic that kids are now more likely to develop an eating disorder than they are to develop obesity because of all of the images and the narratives that have been put out there. So that's most certainly the most difficult part about being a dietitian, is kind of trying to help people come to terms with their genetic blueprint, diet culture, and sort of be at zen with their bodies, while also trying to help them improve their health. So I think we conflate weight and health, and that's by far and away the hardest part of being a dietitian.
Oh, absolutely. So you wrote a book, which actually is sitting, I have all the books, but sitting on my bookshelf. I get it for my interviews. It's not because I'm like, oh, let's look not for me. That doesn't pertain to me. But you wrote a book called, co-authored it.
Correct.
Epilepsy in Children, What Every Parent Needs to Know, and you specifically co-authored it with Erin Conway and Orrin Devinsky. Can you tell us, I guess, and give us a brief overview of what this book entails, and what specifically, or what parent should maybe pick up this book in comparison to just say some other parent that it won't necessarily pertain to?
So when we decided to write this book all together, it was really based upon like our joint experience with our patients. And before this book, we realized that there had just not really been an updated version of a child's parent's guide to when your kid gets diagnosed with epilepsy. So, I mean, anytime your child is diagnosed with anything, a food allergy, and, all the way to a chronic illness, you kind of don't know where to start. So the book was written with the intention to sort of be a voice speaking to a parent in understandable language, if that makes sense. We really didn't want to make the book super heavy medical terminology. We really wanted it to be something where you could say, okay, I was told my child was diagnosed with epilepsy last week. I'm not sure where to start. Who can I talk to that will speak in my own language, instead of, doctors are talking to you and sometimes they're saying big words and you don't know even what to listen to when you're first diagnosed, because you're sort of in shock. So that was really the intention behind this book. We really wanted it to be kind of like a guide where you can start out by seeing, okay, what is epilepsy? In a way that I can understand as a parent, and what options are there out there for me in terms of treatments. So, you could Google epilepsy on the internet and hit 50,000 pages that will all say something a little bit different. So we tried to bring it all together here with the experience of, me contributing some of the more, we call them adjunct therapies, which are not necessarily medicinal therapies, and then Erin and Orrin bringing their medical expertise. And Erin really is the one interacting with the patients on a daily basis, so she's the one who knows how to kind of speak in that voice that they understand. So we thought that it was kind of a good collaboration, kind of coming from all different angles, so that a parent can really look through the book and say, you know what, I'm not interested in medication, so what other options do I have? Well, you skip ahead to the non-medicine chapters and you can kind of read through and see, okay, what is the evidence out there on craniosacral therapy? Is there strong evidence for it? What is the strongest adjunct treatment evidence-wise? And that's why we wrote this book, because it really just hadn't been updated in quite a while. And Dr. Devinsky knows everything there is to know. He's got,
I know,
lots of experience working with patients of all ages. So who better to write this book with? And that's really what it's intended to be. It's intended to be a book that you pick up and you're like, I really want to learn about my child's diagnosis and where do I go from here? And you can kind of look back at it as a guide. It's definitely not a book where you could say, oh, after reading this book, I can start the ketogenic diet, or after reading this book, I can start craniosacral therapy. It's kind of just meant to be like a segue into what are my options.
Right. Absolutely. And a lot of books say, this is not like to be a clear diagnosis,
right,
or that this is going to be the be all and the end all, like consult a medical professional.
Of course, it's to help you better understand where you might stand after hearing a diagnosis.
So we spoke a little bit about this, but I guess to maybe just get the short and sweet of it, how does the keto diet treat or co-treat with medication seizures?
So we, there's a few schools of thought, and it hasn't really been well researched because it's sort of a difficult thing to research. But the belief is that this shift in metabolism from using sugar to using fat as our main energy source sets off a different metabolic pathway. There is a whole cascade of hormones that are triggered when we eat. So when we eat carbohydrates, insulin, which is an inflammatory hormone, is increased. Insulin then triggers other inflammatory hormones like cortisol. When you're not eating excess carbohydrates, you're really not getting that whole insulin cortisol pathway. So that is suppressed, and that will create an anti-inflammatory state. So that's one theory. Another theory is that the ketones are able to pass through the blood-brain barrier. There's not a lot that can pass through there in terms of nutrition. Proteins don't pass through the blood-brain barrier, only sugar and ketones can. So the decrease in sugar reabsorption through the blood-brain barrier and the increase in ketones, they think can change neurotransmitter activity. So there are a few different schools of thoughts, but essentially the take-home message is that this shift in metabolism from using sugar to using fat as your main energy source does something in the body which tends to, suppress seizure activity in some people, and it doesn't work at all in other people. So we don't know upfront who it's going to work for and who it's not. It's just like medicine. So one person may start a medicine and it works beautifully for them, and then the other person, same height, same weight, same seizure type, can start the same medicine and it won't work at all. We don't have good insight as to why and who will work, for what, but we do know that shift in metabolism it's the key to something.
Of course, yeah. And are there is there any upcoming or current research, whether it be with Dr. Devinsky or other neurologists or epileptologists that are, and obviously dietitians as well, on this? I mean, on how keto treats epilepsy, because it should probably
there
be
definitely
well known.
Yeah. There definitely are. We actually had participated in one where they were analyzing, it was elective, you had to go on the diet. These were people who were having surgery. They already had brain surgery scheduled. So they were either getting a VNS or they were having tissue removed. So these people would then electively start the diet to see if there were any changes in the tissue of the brain. So there definitely are ongoing studies. That's just one of the ones that we were looking into, or we were part of it at NYU. But it's a rather difficult thing to study because it's diet related. Diet studies are generally not well funded. Basically, medicine studies are well funded. The NIH has so much grant money to give away, but to supplement that, generally pharmaceutical companies are supplementing studies. Pharmaceutical companies aren't going to fund a study in which the antithesis of their product is, being promoted. So unfortunately, it's not a really well studied piece of epilepsy. With that said, a lot of our information comes from what we call like longitudinal studies. So we follow people over time, and we kind of watch their reaction. These are not like clinical trials, so the research isn't as strong, but it's there. The research is most certainly there with the diet. It's just not, we're not doing clinical trials with the diet. So there are plenty of longitudinal studies going on at all different centers around the country in terms of epilepsy and diet outcomes.
Yeah.
But trying to pinpoint that metabolic reason why the diet works, I'm not 100% sure that those are ongoing at the moment. I'm sure at some point, a drug company will try and figure that out so that they can deliver the same result via, instead of having to follow a diet, maybe there's a drug that can take care of it. That I'm sure that will happen at some point, that somebody will look into it. But in terms of the diet, it's very difficult to implement these studies because you have to get compliance. You have to have, there are long studies. So there's probably not a whole lot of like clinical trials in terms of the metabolism being studied.
Yeah, I'm sure over time there will be more.
Yeah.
But okay, so and there's something that actually people may be interested in. So they're clearly it's like coming up left and right. I feel like it was just the other day New Jersey passed it. But for epilepsy and other medical conditions, but we're going to focus on epilepsy, medical cannabis, which he was on the forefront of, can be used to treat epilepsy. Now, can cannabis be used also as a supplement to the keto diet, or is it really more towards just people who are taking, traditional, epileptic meds that are, pharmaceutical? I mean, not that medical cannabis isn't pharmaceutical, but it's a different type of drug.
Sure. So the diet, and because medical cannabis is relatively new, we won't have a whole lot of like long-term studies with the diet, but we most certainly have children and adults using Epidiolex, which is the non-THC version of medical cannabis. They're using Epidiolex with the diet, and we've had no issues thus far, but it's most certainly being done. We have, a number of people on both. So they definitely can work together.
Okay. No, that's great for people to know. All right. And then lastly, I guess what message or what advice would you give to parents who who basically have a recent diagnosis of epilepsy? They're seeing X, Y, and Z epileptologist. When do you think they should ask their doctor about the ketogenic diet? Not everyone is like Orrin, that's like, oh, maybe this should be, maybe
Correct.
You should do the keto. So like, when should they ask and inquire about it?
I would do that before you even pick your epileptologist. So for me, if I'm looking for a neurologist or an epileptologist, I'm going to look for somebody who is a bit more progressive with the newer therapies. I would also want to make sure, even if it's not something this epileptologist is comfortable for, does their center offer diet? Does their center offer adjunct therapies? Like, have they done any trials with medical cannabis? Where are they in the forefront of epilepsy treatments and research? So that would be an important first step in picking my epileptologist. Then it would be one of the first things that I spoke about with my my care provider. I would really want to know, what are your what are your thoughts on the adjunct therapies out here? I think it's really important to be open to what the doctor suggests. So, you may be anti-medication, you may be pro-medication. These epileptologists have been practicing for many, many, many years. So you have to trust them on some level. But I think it's really great to get their take on, where are you with diet? Would you try it first? Would you try it after we failed medication? What are your thoughts? If they're not in line with your thoughts, you should probably find another practitioner. So if you go to somebody and you're like, listen, what if we fail Keppra and, Felbitol, where are we going to be at? And they're like, well, we'll try these 5 medications. I wouldn't try diet until it's a last resort. If that's not in line with your thinking, then you should find somebody who will visit some of these alternative therapies sooner.
Right.
With that said, we generally recommend, the rule of thumb is that you try at least 2 medicines before you begin the diet. And that's only because the diet is an extreme lifestyle change. So, as a parent, I can see how difficult it is to just feed a toddler who is picky, let alone on a restricted diet. So the caveat to that is that the earlier you start the diet, the easier it is. So if you have an infant, you're just changing a formula. If you have, a baby who's just starting solids, they're already eating purees. It's not a huge lifestyle change. The older the person gets, the older the child gets, the more difficult it becomes because they develop preferences, they develop a personality, and then they're at social engagements, which make it even more difficult. So it's a very tricky question. But it would be one of the first things I brought up with my practitioner, hey, where do you stand with the diet? If you're planning to start the diet, you would want to do it sooner rather than later. If you do fail, 1 or 2 medicines, because the sooner you start it, the younger your child is, the better. And you also have to make the determination of whether you're willing to put in the work to maintain the diet. So there's kind of a lot of factors that go into it, but it's something that I would definitely bring up within your first few meetings of where do they stand on some of these alternative therapies, because they can be extremely useful. And you don't want to feel like you got, 3 years down the road and didn't know that this was an option for you. You want to know what your options are right from the get-go.
Absolutely. Well, amen to that. Mazel tov. So this was wonderful. You're great, Courtney. So thank you so much.